Hello everyone, my name is Suresh. I've been working for about 16 years as a senior physiotherapist in a community unit in Dublin, Ireland, providing services to older people 65 and over in both long-term care and day care settings. The topic is about a study for the Quality Improvement Initiative on optimizing bed height to reduce long-term resident falls from bed. In order to improve resident safety and reduce hospital admissions, the Optimizing Bed Height Quality Improvement Study aims to raise awareness among healthcare professionals about the importance of ensuring optimal bed height to prevent falls and injuries in residents and to improve bed mobility. The Ireland Health Service Executive Patient Safety Strategy 2019 to 2024 was the benchmark for this study. Bed fall statistics have been taken from the incident report and analyzed, with a view to identifying causes of bed fall and possible improvement areas. The parameters from a 2015 study, Analysis of the Influence of Hospital Bed Height on Kinematic Parameters Associated with Patient Falls During Egress, are taken into account when using intervention techniques. Let's see some of the reasons why the resident had a fall from bed. 1. The incorrect height of the bed after ADLs goes unnoticed by the healthcare staff. A study conducted by Lopez, Gerling, Carey, and Kanak in 2010 concluded that when tasked with a very heavy workload, nurses tend to focus on primary jobs such as patient assessment and medication administration and neglect secondary jobs such as adjusting bed to a low position, rounding to assess patients, setting bed alarms. Thus, neglecting these secondary jobs, such as adjusting the bed to a low position, could possibly lead to failing to prevent bed-related falls. And another study conducted by Seng in 2010 shows that in adult acute inpatient care settings, 51.4% of all inpatient fall incidents and 56% of injurious falls are associated with an activity related to the bed such as transfers to and from bed. And Oliver, et al., in 2010, affirmed that most falls occurred from beds or chairs, attributed to suboptimal height furniture, an environmental risk factor that is modifiable. The second reason was, after cleaning underneath the bed, the cleaners either neglected to lower the bed's height or didn't know what was right. The third reason, there was the lack of a specific type of bed like height-adjustable floor bed. In the case of a mobile residence, the purpose of the low bed position was always to reduce the distance between the bed and the floor when a patient fell from the bed. The severity of injury will decrease when there is less distance. In the case of mobile residents, height-adjustable floor beds which can act like normal profile beds will support bed height that can be individualized based on an assessment of patient's height, muscle strength, pain, balance, gait and more. There was an interesting study by Chrisman, et al. In 2015, analyzed the sit-to-walk kinematics of older adults exiting a bed at 3 different heights, high, medium and low. The movements included body movement initiation, beginning to stand, lifting one seat off the bed, and heel and toe movements to walk away from the bed. Testing 65 older adults during this study, the researchers found that bed height significantly influenced patients' ability to seat off the bed and then swing off and start to walk. This research supports the increased fall risks that occur when older adults with strength, gait and mobility impairment attempt to perform sit-stand walk from a low bed position. The low bed height created a more posturally challenging transition and require more time to accommodate balance impairments which used the same momentum strategy as the other bed heights. Medium bed height allowed older adults to rise at a rate that felt stable, yet enter into gait with a fairly high degree of fluidity. High bed height in contrast enabled the older adults to perform the same sit-to-stand task with slightly faster times. The study objectives are 1. To determine an optimum bed height that is low enough to reduce the risk of fall-related injury. 2. To determine an optimum bed height for safe mobilization from the bed to enhance resident safety. 3. Empower and implement a change practice strategy, which involves multidisciplinary team approaches to anticipate and respond to risks to patients' safety when managing falls from bed. Let's see the methods employed in this study. Residents' bed fall statistics have been taken from the incident report and analyzed, with a view to identifying causes of bed fall and possible improvement areas. The number of residents aged 65 or over falling out of bed between January and June of 2022 was used as a pre-test measure. Nurses and physiotherapists assess residents' mobility and determine the bed's optimum height, and trained other staff on the importance of bed height and setting the bed at the optimum height. By maintaining a hip or knee angle just above 90 degrees. Keeping the residents' feet flat on the floor, and ensuring that they can easily transition from sitting to standing and vice versa, the physiotherapist and nurse assessed the resident's mobility and determined the height of the resident's bed. An illustration of the ideal height is displayed on a poster that hangs on the wall above the headboard of the bed. Nurses visit each resident's room daily to ensure the bed is in the optimum position, recorded in a monitoring system and discussed in a monthly fall committee meeting which served as a communication tool. The bed fall data obtained during the 6-month period of intervention from July to December 2022 was compared with the pre-test results. You can see a poster illustrating an ideal height that was displayed on the wall above the headboard of the bed. The poster reminds cleaners and all healthcare staff to check, correct, and maintain optimum bed height. Now you can see the video showing a poster on the wall. Let's see the results using graphic representation. When results from a 6-month intervention period, that's from July to December 2022, were compared to those from a 6-month pre-intervention phase, that's from January to June 2022, with 14 bed falls, there was a 50% decrease in bed falls. So, after a 6-month clinical trial, the study revealed that older adults who had bed falls and trouble getting out of their beds had lower fall rates, suggesting that stakeholders' knowledge of the ideal bed height had increased. The learning points and recommendations from this study are: for each resident, identify the optimal bed height and type, and display it on a poster. Educate all healthcare care providers, including cleaners and agency staff, about the poster and the importance of proper bed height. Perform periodic bed height inspections and record them in the monitoring system to ensure compliance. Other healthcare personnel should alert the nurse in charge if they notice any deviation from the recommended bed height. Poster marking reminds cleaners and all healthcare staff to check and correct bed height. Bedside fall statistics captured monthly and discussed during the Falls Committee prove valuable in mitigating falls. Every 4 months, during the moving and handling review, bed type and height should be checked, as well as whenever the resident's mobility changes or when they had a fall. In contrast to profile beds and low-entry beds, floor beds can be adjusted in height, making them suitable for all types of residents, including those who are mobile and those who are not. This measurable study does not require any funding, which would facilitate the adoption of strategic objectives and the implementation of feasible intervention techniques by a number of community units in Ireland, the UK and worldwide. Many thanks for watching this video. Like and comment. Please share and subscribe.